There we go.
You're gonna have her put the questions in the group chat or on the Facebook Live?
So this is YouTube Live, and I have Emily putting, any questions she has in the group chat. Yeah, so, Katie, you're in charge of group chat? You're looking at it.
Well, Steph said she's on her way to people who found mistakes.
Okay. Well, she needs to plan earlier. She does. We love you, Steph, but you need to plan earlier. I was just kind of hoping maybe this thing would work. Why would it work? I didn't put up this one time. So I'm gonna have to put it up there. Did we determine if we tap, right, arrows here, okay? We do. There we go. So chapter 14. So hopefully Emily has tuned in by now. And you missed it. When we got here, we did not have a classroom. Our classroom was dark, it was locked, we had nothing. So if you look in the group chat, you'll see Katie actually put up a picture like, uh-oh, Kai's gonna lose her mind when she gets here and sees this, and I pretty much did. So the nice people at Sullivan BOCES were gracious enough to supply us with a different classroom, and we decided we're gonna try and break the other classroom because we like this one better. If I had to guess, I would say this is probably where you guys are taking your exams.
Oh, really?
That would be my guess. We need to do something about the temperature in here though.
Yeah.
If that's gonna be the case. Yeah, I know, we can't have this hot nonsense. I'll bring the fan in. So, alright, so Emily, if for some reason the phone slips, I have it like held up by a stapler and a tape dispenser because I'm extremely resourceful. If it slips, I'm not gonna be able to tell. Just let them know in the group chat so we can fix it, okay? Otherwise, this is just chapter 14. I'm gonna stop this one when I'm done and do a separate one for the NHA review. I'll kind of be all over the place, but you'll get the point. Some of point of care we have already done, okay? And that's blood glucose. You guys are like an expert at blood glucose now, so that should be pretty simple. Of course, that's simple. All right, so point of care testing. Let's talk about some of the terms that we're going to use for laboratory services beyond just the hospital setting. So the one that I want you to know, point of care, I want you to associate with tests that if something goes wrong, it's not going to kill the patient. They tend to be relatively low tech, okay? So things like blood glucose, things like hematocrit testing, arterial blood gases, stuff like that, like the quick machines. Anything point of care related is CLIA waived. You're going to see questions on the test about CLIA waived. Anything that is CLIA mandated has to have these really super high-tech quality controls done on them, like big-time stuff. Point of care testing also has quality controls, but it's like little. So there is a couple of questions on the test about quality controls when it comes to glucometers. And one of the questions specifically asks about when you're going to do your quality control tests on a glucometer. And the answers are something like every time a new operator uses one, once a week, before every patient, once a month. So this varies in your hospital. If you are working in an outpatient lab, typically it's once a week you're going to do quality controls. If you're working in a hospital on the floor, you're going to do it at least every day. Like usually there's going to be one shift that's responsible for it. Oftentimes it's nights. If you're working in an intensive care unit or an emergency room, you're going to be doing it at least twice a day. Usually it's like Q shift, all right? But for the test, I think the answer that we're looking for is weekly. We're going to go over that question when we do NHA exam review later on, okay? And we'll be able to look at that and I'll remember exactly which one it is. The other one has to do with getting glucometers. Let's say you work for a doctor's office and you acquire another doctor's office, or many if you work for Hackensack Meridian. And so suddenly their equipment also becomes your equipment. So you have brand new glucometers that are in your current office, and now you just got a whole bunch more glucometers from another office, which are older, but still in perfectly good use. And the question has to do with which ones are you going to do quality control on? The answer is all of them. Okay, so it doesn't matter if your machines are brand new or older, you're still going to be doing quality controls on them. Okay, so there's a little tip for questions. So you'll see bedside testing. So that's like when you're in the hospital and somebody comes up and they're like, "Hi, you're in the hospital for DKA, I'm gonna stick your finger while you're in the ICU literally once an hour. So that's something you will literally bring to the inpatient setting at the patient's bedside. And there's lots of different tests we can do, but I talk about glucometry a lot because it's the most common one after you check blood sugar checks. Okay? Hi, come have a seat. We're videoing, so. All right, so those are the ones that I want you to be familiar with, okay? Point of care testing, bedside testing. Don't go crazy with all the other ones. You guys can always skip over stuff you don't need. Okay, so the demand for point of care testing is increasing because it's fast. If somebody does a venipuncture for blood glucose, it can sometimes take a couple of hours depending on how backed up the lab is. So if we careful stuff because the camera's like right in front of you.
That's okay.
So I didn't have time. You know, if I need to give a patient insulin, if you know my patient doesn't feel good and I need to determine what's going on, I don't have time to wait for results to come back from the lab. This stuff is like immediate most of the time. We have patients in respiratory distress. We have patients possibly in DKA. We have patients that we think may be in septic shock. We're going to do blood gases. All right, that's something we can also do at the bedside. Point of care testing is fast. It's a wonderful thing. Point of care instruments use very small amounts of blood and they are not spun down. They're uncentrifuged. Usually it's just a drop or two of blood from the finger. That's it. Most of the time it's blood. Sometimes we can do urine. Can somebody think of point of care testing we did recently with urine? Yes, dipsticks, exactly. That is point of care testing. Very low technology, guys, right? It's a little stick and you compare it to the colors on the tube. Low tech, right? Saliva can be different things, but the one you're going to see the most is blood and often. Okay, so let's talk about some of our more frequently used point of care tests. Electrolytes in blood gases, we just talked about. Glucose, that's your most common one. Hemoglobin A1C can be done with a finger stick nowadays, you guys, which people like me are very happy about because they don't have to spend forever looking for a vein for me to get an A1C done. Now when I go see my endocrinologist, they stick my finger and it takes like, I want to say it's like 6 minutes, 8 minutes, something like that, and then it pops up with a number, which is awesome. Hemoglobin we can do, see if our patient is anemic, hematocrits we can do. They do have rapid HIV tests, but they tend to have false positives, false negatives. I'm not a huge fan, but they do exist. Rapid flu, has anybody ever been swabbed for rapid flu? You're in the ER or the urgent care and they're like, oh, I think you have the flu. You probably do have the flu, but we're gonna swab you anyway, just to be sure. Those also have incidents of false negatives. Lipids, we can do cholesterol tests now. Pregnancy, guys, everybody's probably peed on a stick at some point in their life. Pregnancy tests are awesome. I know, so we're filming right now, so be careful not to knock the phone. So pregnancy tests are very simple. In pregnancy tests, we're looking for the presence of a hormone. That hormone is either there or it's not. It's very simple. And that hormone is what? Can anybody tell me?
HCG.
HCG, very good. Nice, ladies. So we're looking for HCG. The only other time that HCG would be present in anybody's system is certain types of brain tumors, okay? But that is like super duper rare.
I thought it was in men too for prostate cancer.
I've never heard that, but that's entirely possible.
I feel like, I mean, I could be wrong.
We got
feel like
somebody,
I've heard
right,
that.
extra credit, somebody Google that, because now I want to know. And forever learning, so that may entirely be the case. And BNP. BNP is something different than BNP, guys. These are all simple tests. If you have never had to pee on a stick before, bless you. Diabetes, okay, I'm not going to go crazy talking about glucose monitoring because you guys have been doing glucose sticks for weeks and weeks and weeks now. You guys are experts at them. You are diabetes out, having a diabetic instructor. By the way, guys, is it true?
Testicular.
Oh, testicular, awesome. So what does the article say? Educate us, now that you closed it. Sorry.
read a post about a man positive pregnancy test appears to have alerted him to test for human tumor. Pregnancy tests detect beta human chronic. HCG,
Right.
a hormone in the blood and the urine produced by the development of the placenta. Experts say beta HCG can also be a signal of testicular cancer.
Awesome, so that's interesting to know, guys. Very, very interesting. Cool, thank you.
I don't know why you begin a pregnancy test, but.
Me neither, but, you know, that's interesting. Maybe he did it to, maybe his mother was keen on his stick and he was trying to be supportive. You're all pianistic too, and, well, get your guys to pianistic, guys. So even those little, dollar store pregnancy tests, they still work because either the HCG is there or it's not,
You
you
can
know,
get like 30 for like $4.
Right.
Yeah, I remember that buying that little expensive one that says pregnant.
Yes. I know, they use like $20 for one test and right.
Oh no, that's the one that tells you pregnant and smiles.
Yes, like.
Yeah, it smiles that you're pregnant and then it frowns at you if you're not pregnant.
Yes.
I don't think I want that.
And I'm like, wait, it should be the other way around.
Yeah.
That'd be no good. So I got my Dexcom finally came, you guys, which is just life happiness. So I still have the pod for my insulin pump, and now this bad boy tells me all the time, 24 hours a day, what my blood sugar is.
Nice.
I do have a receiver, which is, it's just a little gadget. It looks like a Palm Pilot, the Palm Pilot. But it goes to my iPhone.
Yeah.
And the software, the Dexcom app on my iPhone, also has sharing software. So Tommy has the same app on his phone, and he can see what my blood sugar is at all times too, which is awesome. So he's so cute. Like, I'll be low at work, and he'll send me a little message like, "I see your sugar. Are you eating?" Like, it's really sweet. Yeah, have something to eat, or hey, did you take your insulin with dinner? Because your sugar's on the high side. It's awesome. I love that stuff. It is. So, guys, we know all about diabetes. How many different types of diabetes are there?
2.
3.
Yeah.
5.
No.
There are
5.
5 different types. Your type 1 produces no insulin whatsoever. Type 2 produces insulin, but body doesn't know how to use it. Type 1.5,
Yes,
which
that-
is LADA, latent autoimmune diabetes of adulthood.
Gestational?
I'm sorry,
The diabetes, yeah.
I didn't say that yet.
Oh.
I said that first. Yes, that's important. Gestational, yes. Gestational is what I like to call type 3. LADA is type 1.5, where you are in fact a type 1 diabetic. Your pancreas does crap out, produces no insulin, but they tend to be, if your pancreas hangs in there much longer, you tend to be diagnosed in adulthood. We have diabetes that will develop because of a shock to the system, severe infection, sepsis, things like that. And diabetes insipidus, which irks me that it's even called diabetes, because it has nothing to do with glucose. It's all about how much water your body is holding on to. It's kind of neat. So yes, we're like 5 different types of diabetes, guys. It's craziness. So we know that insulin and glucose are a locking key mechanism. You cannot use one without the other. When you have patients that have a lack of insulin, or they have enough insulin but the body, ladies, don't chatty because you're right next to the camera, okay? Thank you. Emily is not here, so Emily is watching by the camera, so shh. So we either have patients that don't have enough insulin like me, or patients that do make plenty, but they have that insulin resistance in type 2 diabetes or in gestational diabetes, where body doesn't know how to use it. Very simple, okay? Now the blood glucose methods that they go over here are through HemaQ. It's an older method that nobody uses anymore. Guys, for the most part, everybody is using, the same blood glucose machine. So I'm gonna kind of skip through and give you guys the stuff you actually do need. I can't see the camera. You guys know where to stick. Which fingers are you gonna go for?
Middle
On the
non-dominant hand.
excellent. Middle and ring on the non-dominant hand. Am I standing too close to this to properly like that? Yep, I know all about that, okay. All right. With point-of-care testing, instruments are calibrated with standards. They all pretty much have to do with a solution in quality control testing. If you open a box of pregnancy test strips, all right, there's a couple different ways you do it in a doctor's office. It's either test strips that look actually kind of like the reagent strips. It's that you just have like the one square and there's either, one line or two, or there's little cartridges where you'll take a pipette and you'll pull up urine from the patient sample and you'll drop it in there. There's the hematocrit testing, there's the ABG testing, all has to do with certain standards. And they have to do with solutions. You're gonna make sure that you the instructions that come with the test are gonna tell you how often it needs to be done. Also, guys, when you open up a new box of strips on any of these types of tests, make sure that they're not expired. If, like, pregnancy tests are a great example. Unless you're in an OBGYN office, if you're in a primary care or an urgent care, you're not doing all of that many pregnancy tests. So it's common that you have a bunch of them in storage and they expire before you even get to open them. So please make sure that you know what the expiration date on your strips are, and that goes for any of these types of tests, guys, okay? Okay, I'm gonna actually go over to my computer because I can't do this standing back this way. All right, blood gases, this has to do with your oxygen, your carbon dioxide, and your pH. Now, there are other things that are measured on your blood gases, but those are the important ones. We're looking at those when we're looking at patients with heart and lung disorders. The most important ones for heart and lung patients are oxygen and CO2. Those two things go hand in hand. pH with the blood has to do with whether the blood is too acidic or too alkaline. Guys, I'm noticing on the exam review that they now want you guys to know more of the lab values, the norms. One of the ones they want you to know is pH. Does anybody remember what a normal pH is?
7.35 to 7.55.
4 or 5. Very good. So normal pH, 7.35 to 7.45. Awesome. So if it is above 7.45, the blood is what?
What? What?
If the pH is above 7.45, the blood is what?
Alkaline.
Alkaline. Excellent. If it is below 7.35, it is what?
Acid.
Very good. So if it's low, then the patient is acidotic. If it's high, the patient is alkalotic. Okay? Low is acid. High is alkaline. I'll give you guys a second to write this down. So this is one of the lab values that they want you to know, is your blood pH. We look at blood gases for many other things other than just respiratory and heart problems. The two most common that we look at them for are patients that are in some sort of metabolic acidosis, like diabetic ketoacidosis, and patients that are septic. Meaning, what does septic mean? Who remembers? Sepsis, infection. Infection in the blood. Yes. Infection in the blood. Good. Okay. So, these can also measure some of the really important electrolytes, like sodium, potassium, chlorides, and calcium, glucose, your bicarbonate levels, and your total carbon dioxide levels. So these are all really important in critical care and emergency care situations. So these are some of the ones that we're going to look at with patients that may be in diabetic ketoacidosis or patients that are in sepsis. Your normal potassium to, yes, she's right, 3.5 to, it's okay, you got the first one. So potassium, that does not look good. 3.5 to 5.5, okay? I've worked at institutions that think that a normal potassium is 3.0 to 5.0. If it's somewhere along that range, that's okay. When I worked for Hackensack Meridian, they wanted it 3.2 to 5.0. So you get the idea, right, guys? So if there's questions about an abnormal potassium, they're not going to give you a low potassium of like 3.0. They'll give you a low potassium of like 2.5 or a high potassium of like 7. All right, so don't, as long as you see it somewhere around this range, they're okay. All right. Sodium. That's why. It's so weird. Okay. Sodium. Sodium is 135 to 145. I saw that they wanted that one. 135 to 145.
You pulled the minus.
The plus and the minus. So when you see it written, they're ions. That's why. So like calcium is written with the little negative. Sodium and potassium are written with the positive. Bicarbonate is written with the negative because these are their chemical formulas. If you take chemistry, then that's what they look like.
Yeah, I don't remember that either.
Yeah.
No,
Yeah.
on the periodic table it's there. It has the
Well,
full
when
name
you're
on top
putting,
and the
yeah,
full
when
on
you're
the
putting
side.
together formulas of this stuff, yeah. So that's, y'all, that's how you'll see the friend. Who can tell me what normal glucose is?
80 to 120.
80 to 120, yes. Now, I noticed for your NHA exam, they're wanting a number of 70 to 120. There is a question on the exam review. It's one of those questions that I disagree with. It's one of those for the test versus the real world. And the question is, you have a patient who is a diabetic, you do a blood sugar. Which of the following results would cause you to call the doctor because you have no orders on this patient? And the answers are 70, 90, 110, and 130. Now, they don't give you any other answer or any other information, okay? Just that those are the 4 possible values. The one that I would have called the doctor on was 70.
Yes.
But the correct answer, as far as an NHE exam goes, is 130 because it's above normal. Nobody is like covering with insulin for 130.
So,
So
he's pretty good.
I know 130 is phenomenal. I think I've been 130 all day. If it was because I was on my daily like 60. So I think it's nonsense, but that's what they want. 70. I mean, they say it's still within the normal range of blood glucose. I guess if your patient feels okay at the moment. But guys, if you take a blood glucose on a patient and it's 86, and that patient is shaky and sweaty, what are you gonna do? You're gonna give them a snack or some juice, as long as it's okay with, either the doctor, the nurse, whoever's, in charge. If you're in the office, just be like, hey doc, room 7's awfully shaky, and her sugar's in the 80s, and I'm gonna give her a little orange juice, okay? And I guarantee, unless they're specifically NPO for procedure, he's gonna be like, yeah, please do. So please treat your patient, not your number. This irks the crap out of me. When I was a patient, years ago, and I'm not even gonna blast which hospital it was out of the water, I had a tech who was so very focused on the number, and my sugar was 79. And I was shaking and sweating, and I was in the hospital, for DKA. Now, I was on the floor by this time, so this wasn't an ER tech, it wasn't an ICU tech, it was a floor tech, they're a different story. But this guy was like, no, you don't need anything, your sugar's still in the normal limits. Okay, but your patient is symptomatic, and I was like grouchy and.
Well, and sometimes that happens when you're starting to shoot lower, and then
Yes.
it starts to get shaky when she's like 90, but she's going down, and
Yes.
it goes down pretty fast sometimes.
Absolutely, and that's my whole point.
Also, I'd rather you be a little bit higher than go lower.
Yes,
where you
and
can
crap out.
survive. Yeah.
Right, and I walk in 20 minutes later and you're unconscious,
Yeah.
and I had no idea. No, you are absolutely right, Katie. Usually if you have a patient that's on the low side of normal, it's because they're on the way down. And if you were to recheck their sugar in 20 minutes, it's gonna be like a crack level.
Yeah.
Yeah, you are 100% correct. Awesome, good. Very good. Okay. Moving right along. Oh, bicarb is a big one, guys. That's one that you'll see doing arterial and venous blood tests on patients that are either septic or in diabetic ketoacidosis. When I'm in DKA, my bicarb levels are like through the crapper. I had a bicarb with 3 months, which I don't think bicarb is one of the numbers that I didn't know, but it's not pretty. All right. Troponin. Troponin is something that we do to measure for heart damage. If you have a patient that comes into the emergency room with chest pain, comes into the urgent care, the doctor's office having chest pain, we're gonna do an EKG, and we're gonna draw cardiac enzymes, okay? Cardiac enzymes. Usually what we're gonna draw is a CK, ISO, and a troponin T, okay? A CK, ISO, and troponin T. Now, we're gonna do both of those. A CK is gonna tell us that there's muscle damage done somewhere. It doesn't necessarily have to be heart damage though. If you have a patient who is in rhabdomyolysis or having like severe kidney issues and they've got damage somewhere in the body, we're gonna see an elevated CK-ISO. But if it's not accompanied by an elevated troponin, probably not heart. If it's accompanied by even a slightly elevated troponin, we know that that patient's having some kind of, ischemia in the heart. All right, probably an MI, myocardial infarction. So that's one of the ones you guys need to know. That's one of the ones that there's a question on the exam review about the numbers. We'll go over that one. All right, coag monitoring. So this is another one, guys, where when we have a patient who's on a medication like Coumadin or warfarin, where we need to be measuring their INRs, it doesn't always have to be via a venipuncture. It can be done via a finger stick and on a test strip into a machine like this, guys. So, excuse me, the coag-check system. Not many doctor's offices have these because they're expensive. But if you are, like there's clinics called Coumadin clinics where these people are coming in and usually they're on blood thinners for things like atrial fibrillation, stroke prophylaxis, blood clot, like DVT prophylaxis, stuff like that. They need to have their INRs checked frequently to make sure they're on the right amount of medication. So they're gonna come in and they're gonna have their fingers stuck. It's a better way of doing things than having to have their arms stuck all the time. You guys don't need to know the different names of these machines. Hematocrit, something else we do. This lets us know how much of the blood volume is accompanied by or occupied by red blood cells. So how many red blood cells are in the bloodstream, basically. It's going to come up as a percentage. So guys, when you see your hemoglobin and hematocrit levels, that hematocrit is a percentage. Patients that are at risk for anemia, we're going to do these for. Or patients that are known anemics, we're going to do this for. This is where you guys are going to use those annoying little microcapillary tubes that I swear don't fill. Drive me crazy. And this is a finger stick. That's what you guys have been playing with the little microcapillary tubes for. Little itty bitty ones. Goes into one of these. Same idea. So these you're going to see in ICUs, emergency rooms. Once in a while, you'll see them in cardiologist's office or urgent cares. The machines that do platelets, hemoglobin, white blood cells, red blood cells, and platelets, those you're going to see at a hematologist, oncologist office. That's a physician, well, everybody knows what an oncologist is, a cancer doctor, right? Hematologists specifically deal with diseases of the blood, but the two tend to go hand in hand. Yeah? All right, so there you go, so you know. All right, cholesterol screening, again, finger stick. We're looking at total cholesterol volumes. HDL and LDL, do you guys know which one of those two is the good cholesterol and which one is the bad cholesterol?
Yeah.
Which is which?
The HDL is the good cholesterol and the LDL is the bad cholesterol.
Yes, HDL is the good, LDL is the bad. Do you guys want me to give you a little trick on how to remember that?
Because the one is lipid, it's like fatty, like grace, you know.
Oh, the
That's
LDL one?
the one that have the L. That is how I remember it.
I'm gonna give you an even easier one, okay? This is like stupid easy, and I learned this in medical system school. Okay, HDL. The H in HDL stands for high density lipoproteins.
Yeah.
There are 4 letters in the word high. There are also 4 letters in the word good. Okay? 4 in high, 4 in good. The L in LDL is low density lipoproteins. Okay? There are 3 letters in the word low. There are also 3 letters in the word bad. Okay? You guys see it? That is literally, to this day, how I remember this nonsense. And if I haven't looked at cholesterol values in a long time, you'll see me think in my head, okay, 4 letters in high, 4 letters in good. That's the good one, okay?
It's a funny way, but because I was in the medical school, they explained me all that process. So I figured out, okay, when you have L, it's mean lipid. So everything just stay like greasy stuff stay there.
Right.
That's
right.
why,
Yeah,
you know.
the bad stuff.
Yeah.
Right. Yeah, but they give you such that,
Mhm.
you know.
Yeah, you basically forget. After they finish teaching you, you just forget it.
Absolutely.
You just remember which one's the good one and the bad one because they never ask you to process.
It's craziness. So yeah, so guys, seriously, that's how I use this to this day. Okay, I have like 100 little songs and stuff like that. If you ever do medical assisting with me and I do the pharmacology lecture, I'm going to teach you a song about anticholinergics and their side effects. You'll never forget. So, oh, I know it's anticholinergic. I'll sing it to you later on. I'm not singing it on the video. All right, bleeding time tests. Don't worry about this one. I'm gonna skip past it. It says you don't need. There are no questions whatsoever, and I think this is
That's the last one.
You guys don't need these. Nobody does. There are no questions on the test whatsoever. Okay. So they're just talking about the last few point of care tests: hemoglobin A1C, maintenance of blood glucose levels. Guys, hemoglobin A1C measures what?
What?
What is a hemoglobin A1C level measure? Over
One.
and what period of time?
3 months.
Excellent. Hemoglobin A1C measures what the blood glucose is over the period of the last 3 months, okay? So an A1C in a non-diabetic is probably going to be below 6. It's definitely going to be below 6, all right? We want a diabetic to be 7 or below. That doesn't often happen. Okay? Now notice, this doesn't look like normal blood sugar levels, right? This doesn't look like 80 and 120. It's a little bit different. When I was pregnant with Jordan, I was on injections. My A1C when she was born was like 8 and change. With Sean, I was on the insulin pump. My A1C when he was born was 4.8. So what a ginormous difference in 1.8, right? Wonderful. And that's why his pregnancy was relatively uncomplicated, and his birth was uncomplicated, and I DC'd my own Foley 4 hours after he was born, and I'm hobbling down to the ICU stand. It was awesome. Okay, Billy Chad, Billy Rubens, guys. That's when we're checking Billy Rubin levels in newborns, right? They tend to get jaundice. They look like little squashes. This is cool because there is no finger stick, no anything stick involved. It actually measures it right through their skin. Babies you can do this with because their skin is so thin, it doesn't so much work with big people.
Yeah, my son had done this, like it was so obvious. And then you walk in and they had him on the gold to protect his eyes, and then he was under the LED lights.
Yep. Jordan looked like a little squash. Did. Rapid HIV, they do. That's one of the ones they do with saliva. But again, they tend to have a lot of false positives and false negatives. I'm not a big fan. Not a big fan.
We stopped doing it through blood. Isn't blood the most way to confirm it?
Yes. And you know, the other thing about HIV testing is if you are exposed to HIV, it can sometimes take up to a year for it to even show up in the bloodstream. Forget saliva. So guys, if you are exposed to a bloodborne pathogen at work, if you have a needle stick injury, if you have a body fluid splash into your eyes, into your mouth, your mucous membrane, your nose, whatever, you need to report it immediately. all right? They need to draw source labs on the person that, you know, you were exposed from, because it's not like, oh, it was exposed and I have it like right now, and you're gonna be able to tell if I have it right this moment. Not necessarily, sometimes it takes up to a year, so please make sure you report it immediately. If you are exposed and you are unable to get source labs, or the person refuses, you can't get source labs, they can put you on a chemoprophylaxis, which basically they're gonna put you on chemotherapy drugs one is for 4 weeks and one is for 6 weeks. There's 2 different drugs we put you on, usually Keytruda and Truvada are the 2 we put you on. And the side effects really suck, but usually they can prevent you from actually getting infected with HIV and hepatitis if you are in fact exposed. But you gotta start the treatment like that day if it's gonna happen, or within like, I think it's within like 48 hours. So it's like report it immediately. You never know, okay? Never know.
I feel like odds are if the person refuses you testing them to like figure it out, they probably have something.
Yes, I have to agree with you.
Because like somebody sent me something with my needle, I'll be like, yeah, sure, like run it.
Right, like, yeah, please, oh my God.
Like I feel like if somebody says no, like it's like,
Right.
yeah.
No, but except the VA's office, when you're doing stuff with the VA, forget that.
Yeah.
No civilian ever gets, like, when my husband needed, just a regular healthcare recommendation,
Mhm.
the grocery shipping told them, we're not giving it to you. Even the job tried to get it from them, and so we had to go pay another doctor to do the whole review.
With the VA guys, things are very, very different. When I worked
Yeah, just
EMS,
the VA shouldn't be.
When I worked EMS in Newark and East Orange, I worked with the East Orange VA. Did a lot of work with those guys, and the rules for the veterans they're different than for everybody else. So, all right, that is it on chapter 14. I skipped over the crap you guys don't need, because I'm not going to jump your head with any extra information. Do we have any questions? No, Emily hasn't asked any questions in the group chat. All right, good. Relatively easy. I have a question, stuff.
Can you tell me again the value of the hemoglobin A1?
Oh, yes.
Yeah.
For a non-diabetic, we want them, a non-diabetic like you are going to be below 6.
Okay.
Okay? A diabetic, we want them at 7 or below. Okay? The lower the better, 7 or below for a diabetic. Yes, ma'am. Okay. All right. So that's it for the chapter 14 point of care testing. Emily, we're going to take a short break and then we're going to come back and we'll do exam review. Yay.
Oh man, do you guys see the